This is our conference is devoted to the heart features, the reasons of the ECG, and the cardiac cycle. All our processes are presented at this one picture. First of all, we start with left upper side. This is the heart and the excitation conduction in the heart. The heart has the automaticity. The autonomic nervous system, sympathetic, parasympathetic nervous system, and a lot of the hormones may regulate the heartbeat rate. But the reason of the heartbeat rate is located in the heart. It is property of the automaticity. It may be spontaneously excited and contracted. The starting point of the excitation, this is the Cyanoatrial Node. The Cyanoatrial Node is located in the right atrium at the entrance of the vena cava. And this is the action potentials in the one atypical myocardium cell in the Cyanoatrial Node. There are, you know, from the histology course, two types of the cells in the heart. This is the typical myocardium fibers or cells. They may conduct the excitation and contracts. And atypical myocardium fibers that had lost their ability to contract and only conduct the excitation. And these atypical myocardium fibers forms the conductive system of the heart. It consists of the cyanoatrial node, atrioventricular node in the septum of the heart, then the bundle of His with two branches, bundle of His, and Purkinje fibers, which go the excitation to the ventricles. And this is the registration of the membrane potential in one cell of the cyanoatrial node. The cyanoatrial node consists of approximately 100 atypical myocardium fibers. This is the action potential and the membrane potential only in one cell, any cell. And the maximum negative electric charge which we register with the help of the microelectrode at the inner surface of this cell, minus 70 millivolts. Minus 70 millivolts. Then there are no resting membrane potential. The potential little by little decreases. It is known slow diastolic depolarization. Slow with the comparison with the rapid depolarization. This is the rapid, the beginning of action potential. And depolarization, this is the decrease of the polarization. This is the maximum polarization, and little by little it reaches the minus 40 millivolts. This is the zero. This is the timeline. This is the electric charge at the inner surface of these myocardium fibers, and it decreases little by little. Why? What is the reason? The ionic mechanism of this process. In the membrane of these cells, the special channels are open. This is the channels more to the calcium ions in second power and the sodium ions, and they start to permeate in the cell. That's why the negative electric charge decreases and it reaches the minus 40 millivolts. And then starts the slow, fast, rapid depolarization. It depends on the permeation only on the sodium ions. like in the nerve fibers, in the neurons, and the skeletal muscle fibers. Then forms the repolarization. The mechanism of the repolarization, outflow of the potassium ions. The sodium ions stop to permeate, to flow in these fibers, and the potassium ions outflows. And then when the potential reaches the -60, the next slow diastolic depolarization happens, and the new action potential starts. The form of the action potential in the cyanoatrial node, in the cells of the cyanoatrial node, a little bit has the other form. This is not the spike form like in the nerve fibers and neurons and skeletal muscles. This is the sinusoid form. Sinusoid, slower change the depolarization to the repolarization. The excitation conducts from the cyanoatrial node, first of all, along the atypical myocardium fibers. They are located in the both atria and reaches the atrioventricular node. Then in all parts of the heart, the excitation conducts from the conductive system to the typical myocardium fibers. The rate of excitation conduction here is equal approximately 1 meter per second. Then the excitation conducts in the bundle of His, and in the bundle of His 3 meters per second, and in the Purkinje fibers with the rate 1 meter per second. This is the small change, 1, 3, 1 again. But at the atrioventricular node, the rate of excitation conduction decreases. And the excitation conducts with the rate 5 centimeters per second. 5 centimeters per second. The atrioventricular node consists of approximately the same 100 cells, and the excitation conducts rapid with the help of the nexus between all the cells, typical and atypical. The close contacts are located like the synapses, but the excitation conducts without mediators, and excitation very rapid jumps from one cell, typical or atypical, to the adjacent cells. But the nexus are no in the atrioventricular node. That's why the distance between the adjacent cells is more, and it needs the more time to jump the action potentials from one cell of the atrioventricular node to the adjacent cells. And it is known the atrioventricular delay, the decrease of excitation conduction. This is very important delay. It is very often askable at the exam because it needs the time to pump out the blood from the right and left atrium to the right and left ventricle. This is the very small period, but it needs the time. Without this atrioventricular delay, the excitation will conduct very rapid, and immediately both the 4 chambers will be contracted at the same time. That's why, first of all, contracts both atria, and then both ventricles. The main characteristic of the excitation conduction, which is usually investigated in the medicine, this is the ECG, electrocardiogram. This is the curve of the electrocardiogram. It consists of the P wave, Q, R, S, and T waves, and the segments between these waves, P, Q segment, S, T segment, and T, P segment, because after this will start the new cardiac cycle, and new P wave will be. what is the electrocardiogram? The electrocardiogram, this is the difference between electric charge on the different places of the body during the excitation conduction in the heart. First of all, what is the reason of the electrocardiogram? This is the excitation conduction in the heart. The excitation conduction in the heart happens with the help of the local currents, like between the Purkinje, like between the distance between in the myelinated nerve fibers, and the local current produce the electromagnetic field, and around this electromagnetic field conducts in all parts of the body, to the head, to the arms, to the legs, and principally we may register the difference between this strength of the electromagnetic field between any points of the body. We may put one electrode on the neck, and the other electrode on the leg, and we register the electrocardiogram. But if each next doctor will register the electrocardiogram with the other types, with putting the electrodes on the other places, we couldn't have the comparison between this investigation with the describing of the change of the electrocardiogram in the textbooks. What is the reason of these waves? First of all, the excitation conducts from the cyanoatrial node. This is the excited part of the atria, and this is the rest part of the atria. At this part forms at the border forms the local current, and this local current produces electromagnetic field, and we register the P wave. We put the electron between two arms, usually, and between the legs. And why we register this P wave between two arms? Because the heart is located in the left part of the thorax, and that's why at the left hand, at the wrist of the head, the strength of the electromagnetic field is more than at a certain place on the right hand, and we register the P wave. Then we register the PQ segment. Both the atria are excited, and the excitation continues in the both atria, and excitation conducts in the cells of the atrioventricular node with slow excitation conduction. The amount of the local current isn't enough to produce the strong electromagnetic field, and that's why we register the PQ segment. This is the time of the atrioventricular delay. We can calculate the time of the atrioventricular delay at each patient. Then excitation conducts to the septum. In the atria, it starts to decrease, it starts to disappear, and the excitation conducts and stimulates the papillary muscles. And the excitation during very short period conducts in the reverse direction. That's why we register the negative P wave, Q wave. If the excitation conducts in the main direction from the bottom to the apex of the heart, we register the positive positive waves on the ECG. If the excitation conduction in the reverse direction, we register the negative waves. This is the excitation conduction in the septum and in the papillary muscles. Then the excitation conducts to the apex of the ventricles, and we register the R wave. Usually it is askable why the R wave is more than the P wave. It happens because the amount of the muscle fibers, typical muscle fibers, is more in the ventricles than in the both atria. That's why this is the maximum amplitude, and this is the right direction, and it is the R wave is positive. Then excitation conducts during the side walls of the ventricles, and we register the negative S wave. The local current will look to the other direction, and the electromagnetic field forms the negative S wave. Then the excitation continues. It continues in the ventricles, and we register ST segment. It is askable why there are no waves on the ECG. There are disappearance of the excitation. This is the resting membrane potential. No, the excitation occurs in the ventricles, but it doesn't move. It continues. The waves on the ECG appears only when the excitation starts in the heart, it disappears in the heart, or it continues, or it moves. It conducts in the certain direction. This is no movement of the excitation, and we register the ST segment. Then the excitation disappears in the ventricles. It disappears in the reverse direction from the apex to the bottom of the heart, and we register the T wave. T wave describes the disappearance of the excitation in the heart. Then starts the diastole, the rest membrane potential in all cells, and we register the TP segment. Then the new P wave will start at the beginning of the new cardiac cycle. At the right part of this blackboard, I present to you the cardiac cycle. Usually the heartbeat rate, the average heartbeat rate is equal 75 contractions of the heart per 1 minute. 1 minute consists of the 60 seconds. If we divide the 60 seconds to 75 heartbeats per minute, we will have not 0.8 of a second, or in milliseconds, it is the 800 milliseconds. I remind you that in 1 second, 1,000 milliseconds. And this is the main phases of the heart contraction. In the atria, this is the systole and the diastole. The systole continues 100 milliseconds and the diastole 700 milliseconds. What is the systole? This is the contraction of any chamber of the heart and pumping out the blood. And the diastole, this is the resting of the heart or the chamber of the heart and filling with blood from the veins. And in the ventricles, we have the systole duration 330 milliseconds, and then happens the diastole here, and during the systole of the atria. In common, it will be 470 milliseconds. If we summarize 330 and 460, we will have 100 milliseconds. But the cardiac cycle consists of the more shorter phases. This is the 9 phases. And first of all, this is the atrial systole, atrial systole. This atrial systole, 100 milliseconds. What happens in the heart? This is the more complicated picture of the heart in the comparison with these pictures of the heart, or that picture of the heart. It includes the main vessels and the chamber. This is the right atrium, this is the left ventricle, this is the right ventricle and left ventricle. This is the entrance of the vena cava, and this is the entrance in the left atrium, the lungs veins. This is the aorta, and this is the lungs artery, the common lungs artery, first of all. This is the semilunar valves. These sticks show us the semilunar valves. They are closed because the pressure approximately in the aorta 120 millimeters of mercury, and here 30 millimeters of mercury. The starting point, this is the atrial systole. These arrows shows this contraction of the atria, and the pressure increases in the right atrium to the 5 and in the left to the 10 millimeters of mercury. And the entrance from the veins is closed with the help of this contraction, and blood flows. These arrows shows the movement, the flowing of the blood from the atria into the right and left ventricle, according to the forming of this more blood pressure. This is the atrioventricular valves. Atrioventricular valves. They are open. This is the tricuspidal valve. Tricuspidal valve. It consists of the 3 valves. And in the left part, this is the mitral valve. It consists of the 2 valves. They are open. And this is the ligaments which attach to the apexes of these ventricles and to the papillary muscles. This is the papillary muscles with Q wave in the electrocardiogram. And they are relaxed, they don't contract because the excitation doesn't reach the ventricles, and the blood moves in the ventricle and stretch out the ventricles a little bit. And after this, the systole of the ventricles will be with more forces according to the Starling law. The more heart in the blood, the more strength of the heart contraction. Then happens ventricle systole will start. This is the beginning of this, and it consists of the 4 phases: first, second, third, fourth, and fifth. This is the picture which describes the process in the heart during asynchronous and isometric contraction. What is the asynchronous contraction? This is the now synchronous contraction. Not all the typical myocardium fibers in the ventricles start to contract at the same time. Some of them, they start to contract when the excitation conducts with the help of the Purkinje fibers. These 2 arrows shows this process. And this is the other Purkinje fiber. And here starts to contraction as well. But between them, the other typical myocardium fibers aren't excited, and that's why they stretch out. And the volume doesn't change. This is the small period of the asynchronous contraction, but the volume doesn't change. After this starts the isometric contraction. isometric contraction, iso, don't change of the volume, or isovolumetric contraction, this is the same. And no change of the length of the ventricles or volume of the ventricles. And what happens? All the typical myocardium fibers contracts at the same time, and the blood pressure increases in the left ventricle from the 10 to 80 millimeters of mercury, from in the right ventricle from the 5 to 15 millimeters of mercury. And the atrioventricular valves are closed immediately. They closed very rapid. And principally, these atrioventricular valves may move to the direction of the to the both atria, this direction. In this case, the blood will flow from the ventricles, from the contracted ventricles, reversely in the veins through the atria to the veins. But it doesn't happen because the ligaments are contracted with the help of the papillary muscles. This is papillary muscles, and the aside wall, the papillary muscles. And these valves prevent the backward movement of the blood. But the aortic valves and semilunar valves in the lungs artery and in the aorta are closed, and all four valves are closed. That's why the ventricles contracts, the blood pressure increases, but the blood doesn't move, doesn't pump out. How many blood? This is the end diastolic volume, 125 milliliters. This is the normal value with the weight of the person, 70 kilograms, and normal striation of the heart. And diastolic volume after the pumping out the blood from the atria. It doesn't need to multiply by 2 or divide it by 2. Here in the right ventricle, 125, and after in the left ventricle, the same, 125. Then starts the rapid and slow blood ejection. One moment. When the valves are closed, they start to vibrate and produce the first sound. The first sound. What is the sound? We may hear this sound with the help of the auscultation. We hear tuk tuk, tuk tuk, tuk tuk. The first tuk is known the first sound. That's why at this moment the atrioventricular valves, tricuspid valve and mitral valve are closed, and they are vibrated and produce the sound. Then starts the rapid and slow blood ejection. The blood flows, first of all, very rapid in the large arteries in the aorta and in the lungs artery, and the valves, semilunar valves, are open, and the volume of the ventricles start to decrease. How many bloods flows out from the ventricles? 65 milliliters. It is known stroke volume. 65 milliliters in the small blood socket and 65 milliliters to the large systemic blood socket. After this, how many blood will remain in the ventricles? 125 minus 65, it will be the end systolic volume, 60 milliliters. That's why not all the blood pumps out from the ventricles, only a little bit more than a half. than a half. And 60 milliliters will be in each chamber, in each ventricle. What happens with the valves? The valves, the semilunar valves, they consist of the 3 pockets: first, second, and third. This is, I demonstrate to you the cross section at this level of the aortic valves. They are closed and the pockets are full with blood. When the contraction happens, the systole, these pockets are pressed to the wall, and this is first, second, third, and the blood flows out in the small and the large blood socket. During this period, the pressure in the atria start to increase a little bit. Here from 0 to 1, 2, according to the movement, the blood from the veins. And in this, from 1 to 2 to 3 to 4. Little by little, the blood flows from the veins, from the large blood socket and from the small blood sockets, and according to diastole, the relaxation, the volume of the both atria start to increase. After this happens, starts to diastole of the ventricles. The blood flows, the pressure reaches from 80 to 120 millimeters of mercury in the left ventricle. In the aorta, this is the systolic blood pressure, 120. And the blood flows to the arch, to the aorta, to the capillaries in the different viscera and tissues. And in the right ventricle, the blood pressure increases from 15 to 30, and in the lungs artery, this pressure maximum is equal 30 millimeters of mercury. Why this pressure is less than that? Because the distance of the small blood socket is less than the distance of the large blood socket. After this, some portion of the blood wants to move reversely to the ventricles, because the ventricles start to relax, start to drift. This is diastole. This is the period of diastole, and the semilunar valves are closed, all closed. You see, this is the closed position of these semilunar valves, and some portion of blood moves out, rebounds from these closed valves, and increases the blood pressure a little bit again. It decreases little by little, but it increases again. It is known like the decrotic increase of the blood pressure. When the semilunar valves are closed, they are closed very rapid with the help of the large big pressure in the systemic arteries. They start to vibrate, and we hear the second sound. Tuk tuk, tuk tuk. The second tuk, this is the second sound. That's why the first sound, this is the closure of the atrioventricular valves, tricuspid and the mitral valve at the same time. And the second sound depends on the closure of the semilunar valves. Then the blood will move from the atria into the ventricles, and the volume of the ventricles will be increased and will start the next cardiac cycle. I present to you the main part of this part of the physiology, and this is very often askable at exam. You should repeat this material. I will send to you this conference. I will send to you this conference and send to you the additional material. You will rewrite